All right, it's 11:01, so we'll go ahead and get started. So a few housekeeping notes before we get started. This webinar is being recorded, and the video will be available on the UH Research and Education Institution, um, also referred to as REI website, after the presentation. Also, please mute your microphones throughout the presentation. If technical assistance is needed, please contact the team here, specifically either Yi Fritz or Abhi Zona Patel. Who are on the call. If you have any questions, please type them in the chat. Questions can be seen by all of the attendees, and you'll have options to submit them anonymously, excuse me, if you prefer, and we'll address those at the end. So with that, it is my pleasure to introduce Dr. Jennifer Villwock. She is a professor of otolaryngology. Yes, I said that right. A fellowship-trained rhinologist, an anterior skull-based surgeon, and the vice chair of research in the Department of Otolaryngology at University Hospitals Cleveland Medical Center. She is passionate about accessible innovation to improve patient care. Examples of this include her research, which has led to the creation and patenting of AROMA, which stands for Affordable Rapid Olfactory Measurement Array. This is a novel objective olfactory test that is significantly more cost-effective and designed for real-time integration into a clinical workflow. Using AROMA as a non-invasive biomarker of dementia and cognitive decline is a focus of her NIH-funded work. She is leveraging a similar sensory dysfunction to identify traumatic brain injury severity and recovery trajectory. She was also selected as a finalist in the NIH National Institute on Aging's inaugural Health Aging Challenge and Entrepreneurial Boot Camp for her work with Aroma. Dr. Villwock subsequently won the Audience Choice Award at the 2003 Alzheimer's Association Pitch Competition and was a finalist for the AARP Age Tech Collaborative at the 2003 conference, Making Aging Easier Pinch Competition. So it is with great pleasure that I introduce Dr. Villwock and look forward to her presentation. Thank you.
Yeah, thank you so much for that introduction. And so that kind of leads us to today's talk, which is all about the special senses and how can we leverage information that we can get about the special senses, which include sense of smell, hearing, and the vestibular or gait and balance system to predict things that we care about, like cognitive risk and outcomes after different injuries or with different pathologies. And so I think sometimes, we should always start with the disclosures, and there are mine. But it can be helpful to start these conversations about like, well, what's the goal or what's the point? Why do I care about this? And for me, my big picture goal is that I really want to help people live vibrant and engaged lives throughout their lifespan. And part of that includes, well, how do we use the information that we can get now, not just to help people live longer, but to actually improve their well span in terms of how long they're living well lives. And of course, I always learn from my community. My work in olfaction started off because I wanted to be able to better monitor patients that have nasal polyps or benign inflammatory growths in the nose. Because sometimes these patients travel a long distance to come and see their friendly neighborhood otolaryngologists. And one of the first things that decreases when polyps start to come back is sense of smell. And so to me, it seems silly that we weren't measuring that. And then come to find out that the real big public health win here is that studying sensory dysfunction, especially olfaction or sense of smell, can provide insight into things like healthy aging. And so taking a step back, why olfaction? And we kind of already talked about why it matters for patients that have nasal polyps, but what about the rest of us? And so we know that olfaction is important for a number of things just in our daily lives, right? So natural gas is impregnated with a scent so that we can detect that scent when there's a leak. It's also important for things like food selection, right? So when this is a picture of my daughter from way back when, she's much older now, but going around apple orchards, sometimes she would think that it would be a good idea to pick up a rotten apple from the orchard floor. nose with great idea. And so this is a defense for us to help identify hazards and avoid them. And we're going to talk a little bit about how olfaction is really linked to visceral memories. And so that's why brands actually care about what does their brand smell like, because for most things in a commercial market, they would like for people to consume stuff. And so if you can have a sensory experience that is pleasant and that triggers people to consume, you're going to make more money off of that. And so this is actually a very robust industry as well, just figuring out how to get consistent smells that will trigger those associations. But when we take a step back and think about, well, what does this mean for us in our daily lives beyond safety and beyond food selection? I think most of us will resonate with this quote. Nothing is more memorable than the smell. One scent can be unexpected, momentary, and fleeting, yet conjure up a childhood summer beside a lake in the mountains. And especially as we enter the holiday season, I think a lot of us have memories of, entering grandma's house or a family house, and you smell the smell of gingerbread or whatever it is that is always associated with those holidays. And it immediately takes you back, through years and years of memories. And so this is very important and also very relevant when we think about memory and aging. And if you don't believe me, you can believe the Nobel Prize Committee, who awarded the Nobel Prize in 2004 to Axel and Buck for their seminal work in helping us understand olfactory circuitry in humans. And if the Nobel Prize isn't good enough, PubMed also will show you how important this topic is. If you search olfactory dysfunction, and granted, COVID made olfaction cool, a lot of people began studying olfaction in the realm of COVID, but you can see that there's been such an explosion of interest and publications. And so here, this is where if you just type in olfactory dysfunction into PubMed and search for the last 10 years or so, you can see that there's interest with respect to COVID, but there's also a sustained interest, which is decades long, related to olfactory dysfunction and aging and neurocognitive disease, mental illness, and an emerging body of literature in children as well. And if that's still not enough, take it from Dr. Oz, who many years ago, his health show on television focused on a new quote unquote at home Alzheimer's smell quiz that you can take right now. I would probably not recommend some of these scents, and more evidence-based approach is what I would advocate for. But nonetheless, these conversations have been in both the scientific and the lay press for a number of years. And so if you're interested in really a global view of how the special senses shape the way that we and other creatures interact with and understand our world, I would recommend these two books. I know most of us already have enough on our plate and usually quite an extensive to-do list of reading, but these are, one is the adult version and the other is for kids. But this is a great book to really reinforce from an anthropologic perspective how important not just sense of smell, but all the other ways in which we interact with the world fundamentally inform how we survive and thrive. And when we think about olfactory dysfunction, one of the things that has always struck me as very interesting is that a lack of awareness is really common. And the example that always springs to my mind is early in our work developing a new olfactory test, we were doing pilot testing, and sometimes it would be pilot testing in a married couple. And I can't tell you the number of times that one of the people in that partnership would be like, oh, my sense of smell is great, but my spouse or my partner, their sense of smell is terrible. And then when you actually quantifiably test their sense of smell, you can see where this is going. It's the other way around, right? The person who thought they had the great sense of smell actually performed worse than their partner. So lack of awareness is really common, which is why just asking people doesn't really give you great diagnostic yield. But we do also know that when olfactory dysfunction is present, it has a huge impact on quality of life. Like to the point where people write books. They're not the best reviewed on Amazon, but they do exist, which really highlights the importance that sense of smell has in how we relate to our world and our environment. And so when you ask people who have documented disorders of their sense of smell, this is the type of stuff that really impacts them. So you can imagine if you've ever had a bad upper respiratory tract infection or a bad sinus infection, can't breathe through your nose, can't smell anything. Just not being able to smell gives you issues with your ability to enjoy food. And some people increase their food intake to compensate, some people decrease. It's going to give you difficulties in your cooking. I always think about difficulties in eating spoiled food. One of my hypotheses as to why you eat the clinical vignettes of the elderly person who just eats tea and toast, or who shows up in the emergency room with failure to thrive. I wonder if it's because of the increased prevalence of olfactory dysfunction in these individuals. And so maybe they've learned over time that I can't know if what I eat is good or not. And so they might be eating spoiled food accidentally, or they might say, you know what, tea and toast is just fine because it's the only thing that I know reliably isn't going to give me GI distress. So then that leads me to really where I want to focus the bulk of my presentation here, which is the link between olfaction and cognition. So hopefully we've kind of set the stage, right? This can be a big problem, often under-recognized. When it is recognized, it leads to huge problems for the individual's quality of life, also with some important safety implications. So that kind of sets up, right, from like a health services, public health standpoint, this is something that we should be caring about. And hopefully it strikes you as kind of strange that like when you go to your primary care doctor, you know, you get vision screening, you can get hearing screening depending on your age, but no one's really screening for sense of smell. And as we get older and start really worrying about cognition, this becomes increasingly important. And so the first thing to think about in terms of what's happening with sense of smell is that, first of all, you got to smell some stuff, right? It's got to get into your nose. And this slide is meant to represent what's happening during that process. So you got to have something to smell. You got to have mucus to carry it, because most of the time the odorants are not super mucophilic. And so in order for them to get to the cilia, the olfactory sensory neurons, they have to be bound up in the mucus. You got to have functional cilia hanging out in the nasal cavity to sense the odorant. You got to have some supporting cells, and this is primarily what was taking the hit during COVID, which caused a lot of dysregulation and olfactory dysfunction that way. You also have to have intact sensory neurons that can relay the signal up to the olfactory bulb. The pathway to relay the signal has to be intact. So those axons, or the yellow thing going through the purple plate and the cribriform plate, those have to be intact. So when we think about things like traumatic brain injury, where you can get that shearing impact as the brain's kind of sliding back and forth, but those nerves are tethered in the cribriform plate, that would be a way that the signal would be disrupted at that level. And then you've got to have a subsequent pathway that's going to continue to relay that signal, and a central processing station, which is the olfactory bulb, and then onto the higher cortical centers. And then importantly, in addition to those supporting friendly cells, we also need basal cells to help that whole system regenerate. So one of the interesting things about these olfactory receptor neurons is that they are first order neurons. And so this whole system continues to regenerate and turn over during the course of our lives. So then it gets like a little bit tricky when you get into the central component. So no, this figure is not anatomically correct, but it's meant to graphically illustrate what all is happening after we make it through all the steps in that slide that I just showed you. So we know we have the odorant coming on up through. There are some nuances in terms of how different chemical structures and things are impacted and bind differently. The different types of scents kind of map to different areas on the olfactory bulb as well, which is why most of the time when you're doing olfactory testing, you're testing a wide array of different scents. And then once we hit the central or the brain side of olfactory processing, you can see that there's a whole bunch of stuff is happening on the brain side. And what I'm really trying to illustrate here is that if you see those areas with stars, we know that these are areas of the brain that are impacted very early with amyloid and tau deposition and Alzheimer's disease. And so this is the reason why we have known for decades that if you study olfaction in the context of things like Alzheimer's disease or even Parkinson's disease and other neurodegenerative diseases, but particularly Alzheimer's, you will see oftentimes preclinical, so before the neurocognitive symptom onset, that there is some olfactory dysfunction that's present. And so we also have to consider that there are other reasons why people can have olfactory dysfunction. So we won't say this individual's name, but you could imagine, like, looks like maybe this person has some nasal obstruction, right? Nostrils don't seem to be doing an adequate job of letting the odorants get in, etc. And then additionally, there are some conditions congenitally where, for example, you cannot smell allium. So things like garlic and onions, you can't smell so well, but everything else, the signal is relayed properly. So we need to make sure that that's not going on, while we're pursuing the hypothesis that we may be able to predict cognitive outcomes by better understanding patterns of olfactory performance. And the evidence really does support this. And so this is a highlight of some research that's not from my group, but that does continue to underscore how important olfactory dysfunction is, right? So linked to cognitive impairment and the dementia continuum, also linked to overall health and well-being. So there's compelling evidence to support that olfactory dysfunction is strongly correlated, not just with things like Alzheimer's, Parkinson's, et cetera, but with all-cause morbidity and mortality. Specific olfactory patterns are associated with cognitive decline, and I'll talk a little bit more about what we have found in our research. And then this is one from a public health perspective that I have really been thinking about a lot in the last couple of years, is that, well, if we know that there's this strong link between olfactory dysfunction and cognitive outcomes, and we also know that, yes, the majority of people who contracted COVID-19 and got associated olfactory dysfunction from that recovered, but many people did not, right? So what does this mean for long-term cognitive outcomes? Because there's a number of hypotheses, right? You use it or lose it. Is this somehow impacting our baseline neuroplasticity, et cetera, that's going to contribute to a higher burden of dementia disease in the future? And I don't think that anybody has the answer to this just yet. And so this is some of the work from my team that set the foundation for the larger study that we're currently undertaking with support from the NIH. So we wanted to know, well, do patterns of olfactory performance help us differentiate between different disease states? And you can see here that we were trying to differentiate between cognitively unimpaired individuals, those with mild cognitive impairment, and also those with Alzheimer's disease. Because we know that the olfactory epithelium and the olfactory bulb respond differently to different scents, we were also curious to know, well, are there particular scents that are more important than others? So rather than, in this case, you can already see the results, but let's hypothesize that, yeah, we think maybe lavender is really important, and maybe that matters more than just like what you scored overall. And so that's kind of what we see. So we see on the right-hand side here, what you're looking at is figures that show different concentrations of these odorants, and that's what the 1x, 2x, 4x, 8x mean. Composite is just the overall average. And we can see that at every concentration, our healthy elders performed better than those with mild cognitive impairment and those with Alzheimer's disease. And so that is kind of like, okay, seems like we're going in the right direction here. And then what we did is we leveraged machine learning to help us understand, well, what are the scents that are most helpful in accurately predicting if somebody has no issues or if they have mild cognitive impairment or Alzheimer's disease. And we found that lavender was very important here, as well as lemon. And so looking at this in a different way, again, you can see lavender, lemon, clove, and garlic out of the 14 scents seem to be especially important. And what we also did is we got the performance characteristics of our algorithms. And so you can see in the box on the right-hand side, so we have aroma versus aroma and then plus. So you might be wondering, what does the plus mean? And the plus just means that in addition to our aroma test, we also let the machine learning algorithms know things like sinonasal burden of disease, age, ethnicity, gender, etc. But overall, in this smaller pilot study, we see really good sensitivity and specificity, as well as overall area under the curve. And so our algorithms were performing very well. I do want to make the point that not only did we have the algorithms try to correctly classify healthy elders versus those with mild cognitive impairment or Alzheimer's disease, but you could argue, like, do we really need a test for that, right? Maybe I can have a conversation with someone for 5 minutes and kind of figure out, are they unimpaired or do they have Alzheimer's disease? So we also task the algorithms with the more difficult assignment of saying, okay, now tell us who has MCI versus who has Alzheimer's disease. And part of the reason for that is that not only is it a more difficult and more nuanced task, but that's also where a lot of potential public health value comes from, right? If we can identify people really early on in the disease course instead of waiting until they have so many symptoms that we can't like continue to ignore what's going on, then perhaps those folks would benefit most from early triage, more supportive therapies, and also early intervention via clinical trials, et cetera. And the performance characteristics were preserved so that we continue to have good sensitivity, specificity, and accuracy, even with that more difficult test. But then we wanted to know, well, is this really specific for neurocognitive diseases, or is this just reflective of the fact that like a number of things can happen that can cause olfactory dysfunction, and we're just picking up olfactory dysfunction? So what we tried to do here is to do something similar in terms of giving our machine learning algorithms the aroma data, but now instead of differentiating between the spectrum of cognition, we also wanted to know, like, okay, now tell us, if you can, do you think that this olfactory dysfunction is from neurocognitive disease, or is it from COVID-19, or from other sinonasal inflammatory diseases? And so this is a heat map that's showing groupings of patients and their performance based on disease category. So you can see that we had our normal controls, we had some post-COVID individuals, people with sinonasal disease, so this would be like allergic rhinitis or chronic sinusitis, and then our Alzheimer's patients. And hopefully what you can kind of already graphically see here is that the pattern is different, right? The phenotypes seem to be different based on this heat map. And we were also able to graphically represent this with some branching here as well, where we see that even between sinonasal disease and COVID-19, which you would think is similar, but like not really, right? Because sinus disease, there's a lot of inflammation. And whereas with COVID, it was more of the dysregulation because those supporting or friend cells that we need to be intact for the system to work were getting impacted. And so we can see that there's some big branch points there that help us differentiate between those two classes. So that helped us to feel like, okay, we're on the right track with this thought process that these sensory phenotypes help tell us presence or absence of disease, generally speaking, and certainly they tell us if olfactory dysfunction is present or not, but may actually be really useful to help differentiate between different types of disease. And so that made us think too, well, maybe it's time that we fundamentally rethink olfactory dysfunction and how we classify it. Most of the time, it's kind of just been dichotomous, like, yep, you got olfactory dysfunction or you don't. But the overlap between the hearing and the sense of smell systems is pretty remarkable, and especially in terms of the different analogies that we can make as well. So when you get a hearing test, you get all sorts of different data that helps us understand, is it conductive, the reason that you can't hear so well? Meaning like there's something that's like in the ear canal, or the hearing bones aren't working, or there's an issue with the eardrum that's making it so that the mechanical relay of sound stimulus doesn't get to where it needs to go so that your brain can eventually recognize that signal. Or is it sensorineural, right? Are all the mechanical components there, but there's something wrong on the nerve or the brain side? that is making you not hear as well as you should? Well, I would argue that maybe we need to be thinking about olfactory testing in this more nuanced way as well, in terms of, well, maybe there's something conductive, but instead of, the eardrum and the hearing bones, here are the things that would conductively get in the way of the odorants actually going to where they need to would be things like nasal polyps, which is where this research line of inquiry started for me, or things like allergies, sinusitis, etc. Or is it something sensorineural, right? Is it because of Alzheimer's disease, Parkinson's, et cetera, or a traumatic brain injury, which you could argue could be both. So for the purposes of the information that I'm about to share with you, we are conveniently ignoring the fact that just like in hearing, where you can have a mixed hearing loss that's conductive and sensorineural, both of them, we are also ignoring the fact that that can happen for hearing. So what we're seeing here is that, we kind of think that we can help us understand what is going wrong based on how they're performing. So this is a B-swarm plot when we're looking at just control subjects and how they perform. So what we see is that folks that perform high on lavender, typically normal. Higher performance is also seen in women, but here across the board, higher performance in a lot of these scents helps us classify folks as being in our control group. Then what we see when folks have a conductive component of olfactory dysfunction, they tend to be younger. They tend to do lower on the 2x concentration composite score across all scents. Tend to do higher on eucalyptus and peppermint, but tend to do worse on things like rose and rosemary. And so immediately in my mind, I'm like, okay, maybe if our main clinical suspicion is for a particular etiology, then now we're kind of getting to the point where we could hypothesize that maybe there's going to be a different conductive panel versus a sensorineural panel to test these folks. And here for sensorineural olfactory dysfunction, again, we see low performance on the 2x concentration, also low on things like garlic and lavender. So further underscoring, that maybe we're onto something with our hypothesis about these olfactory phenotypes. Which then led us to think, well, I already mentioned how there's kind of a lot of overlap between the olfactory and the auditory systems. Let's throw the vestibular system in there as well. And yeah, can we learn additional information if we start assessing multisensory dysfunction? And so hopefully y'all already still have this figure in your mind in terms of the neuroanatomy of olfactory function. Well, it turns out you can make a really similar figure for the neuroanatomy of multisensory function. And so this kind of underlies why we think that there may be additional value in understanding auditory as well as vestibular performance, not just olfactory performance, for assessing overall brain health. And so to address this, what we did is that we took 180 subjects that were presenting to the ENT clinic just with subjective hearing loss. So that was their main complaint. Like, I just feel like I'm not hearing as well as I'm supposed to. And what we had these folks do in addition to their formal audiogram was they also got our aroma or our olfactory test. And then as a proxy for vestibular function, we had them do the timed up and go test, which is just a physical task where they start seated, stand up, walk a prescribed distance, turn around, come back and sit again. And then we also had them do the MOCA, or the Montreal Cognitive Assessment. And what we found is that overall, 31% of people screened positive for MCI on the MOCA. And again, these folks did not have any cognitive concerns, just had concerns about subjective hearing loss. When we looked at the impact of sensory impairments, what we found is that compared to folks with no sensory impairments or just one sensory function was wonky, if you had two, so hearing and balance or hearing and olfaction, the odds ratio of having mild cognitive impairment on the MOCA at that time was 5.32. So kind of a big jump. But if you're looking for a big jump, Look at what happens when you have 3 sensory impairments. The odds ratio is 15.7. And this is a big deal to me as an otolaryngologist who takes care of patients and their special senses in the head and neck, because, and we'll talk about this in subsequent slides here, we also know that these sensory dysfunctions are amenable to rehabilitation that can be done very cheaply and even on a home-based or outpatient method. And so this is a graphical representation of other ways to visualize that data. If you look at the blue box, I like that the olfaction dot outpaces the gait and balance and hearing, just because olfaction is my primary jam in terms of what's contributing to the heightened incidence of cognitive impairment. And you don't have to take just my group's word for it. Other people are looking into the importance of multisensory evaluation as well. So tinnitus or ringing in the ears is another problem that we see commonly in our practices as otolaryngologists. And so this paper was studying tinnitus and olfactory dysfunction. And what they found is that increased ringing in the ears was associated with both subjective and objective olfactory dysfunction related to hearing loss, vertigo, headache, etc. And so to me, this all goes towards, well, you don't know what you don't know until you start looking into it. And so I think, again, that multisensory dysfunction and certainly including olfactory metrics into clinical care, if not clinical care, at least into research for these overlying topics, is a significant missed opportunity if we continue to not do it routinely. Taking us back to COVID-19, do we have a looming wave of dementia? Nobody knows, right? But there's a lot of literature that continues to emerge about why maybe we should be thinking intentionally about this population. So we do see that there's generally decreased gray matter volume in the olfactory regions. There's some inflammatory mediators, even in the absence of any active viral infection. What about kids, right? We know that 1.7% of them have long COVID symptoms. Maybe this is why kids are picky eaters, right? Things smell bad or wrong, or they just don't taste good. Like what should we be thinking about long-term for them? And then, of course, the cognitive and long-term dementia risk as well. So I'll just conclude here with some thoughts about where we're going from here. And I know that there's other scientists that are watching. So if any of this is of interest to you, I'll have my contact information displayed at the very end of this talk. Please feel free to reach out. I love to collaborate. But speaking of regeneration, right, and what we can do, I mentioned that as an otolaryngologist, this speaks to my heart because we can do something about these sensory deficits. So looking at 2006, at that point in time, we said, well, we don't have any effective treatment for the most common causes of olfactory loss. So, it's kind of like, well, what's the point of detecting this if it's just a bummer, right? But in 2017, there was a new paper that came out with new information that has subsequently been supported with systematic reviews and meta-analyses that shows that olfactory training is helpful, not just for post-viral olfactory dysfunction, but it's also been studied in the context of traumatic brain injury and other etiologies and shown to help. So if we can remediate that multisensory loss, right? Someone's got 3 senses wonky and we can take them down to 2. If that at a population level reflects a decreased odds ratio of cognitive impairment from 15 to 5, we should be doing this. That's a huge public health win. And so you might be wondering, well, what is olfactory training? So these are pictures that I pulled from, I think, Amazon. They have a bunch of different projects. This is not what we use in our studies of olfactory training. This is just to illustrate that we know that we can increase our sense of smell, right? And we can make it more sensitive. This is what sommeliers do when they're studying for their exams and trying to figure out, like, okay, what should I be smelling to say that this has like hints of apricots and was aged in a specific barrel, etc. And then it cracks me up that there are also specific beer aromas that you can train yourself on as well. Um, Olfactory training is essentially known exposure to odorants, right? So even if you don't smell anything, let's say you got post-viral olfactory dysfunction, you would take the odorant that's lemon, for example. You'd say, okay, brain, even if we don't smell anything, here comes lemon, here comes lemon. And it's trying to harness, the fact that we do have some conscious control and just trusting that all the hardware is there is how I explain it to my patients. And with olfactory training, we're trying to upgrade the software. And so the results of this study, which was investigating olfactory training in patients, both controls as well as those with long-term smell loss, in aggregate, what we're seeing here is where fMRI is showing activity. So generally speaking, more dots is better, and more lines between dots is also better. And so after 12 weeks of training, which would be on a panel of scents, as I described, twice a day, we do see that detection ability is significantly increased. And then also you see this modification of functional connections, right? So something is truly happening at a neuroanatomic level that supports the quantifiable changes in performance on olfactory testing, which is really cool. And then I just want to highlight this study here, which the title of the study is olfactory training with older people, but the title doesn't fully reflect what was done in this study. What they did here is that they compared olfactory training twice a day versus Sudokus twice a day. And as a person myself who I hate Sudokus largely because my brain cannot figure out how to do them, I was really curious to see the results of this study. And what they found is that when you compared olfactory training versus the Sudoku cohort, above and beyond what was achieved by the Sudoku cohort, the olfactory training cohort had better threshold and discrimination specific for olfaction, which makes sense, right? Ostensibly, we were retraining and strengthening the olfactory system. But they also had improvements in verbal fluency, decreased in depression indices, and overall decreased cognitive age, which all goes towards, well, maybe we should be leveraging this innate neuroplasticity and these connections between our special senses and cognition to improve at a public health level these outcomes. So where are we going here at UH and kind of what am I thinking about? Well, there are a lot of conditions beyond, the standard dementia and Alzheimer's disease that I think would be really interesting to further interrogate these hypotheses. So this includes things like chemotherapy-induced cognitive impairment. Can we, by sensory profiles, predict who is most at risk for chemo brain, right? And if we can identify those folks, would sensory rehabilitation or prehabilitation or intentionally making sure that these folks are in a sensory enriched environment help with clinical outcomes? And there is some data to support this. There's a group in China that did a randomized study where they did exactly this. They offered a more sensory enriched environment, including intentional olfactory training in women with breast cancer, and the enriched environment group did better in terms of their cognitive outcomes. I've also become very interested in perimenopause and menopause. I think there's a lot of appetite in the overall population. If you watch the morning news at all, hormone replacement therapy, what to know about menopause and perimenopause, etc., all over the news, right? So it's really in the public conversation. But I'm wondering, as we start seeing treatment paradigms change, it would probably behoove us to understand how things like hormone replacement therapy or other specific therapies impact sensory function, which is responsive to sex hormones. So we do know that the vestibular, the auditory, and the olfactory system performance tends to decrease during this transition. And better understand, what does this mean for long-term dementia risk, right? And compare those outcomes longitudinally. I'm also interested in things that we know are going to alter sensory processing, like psychiatric psychedelic therapy. but not the best option for everybody. So maybe if we can understand who is most likely to respond, maybe sensory testing can give us some insight into this or help us determine therapeutic responses, another quantifiable metric beyond validated surveys for how they're doing after this type of therapy, or help us predict duration of response. And so certainly there's all sorts of ways to investigate this at the basic science side to continue building the mechanistic models for what is happening in these conditions and why does sensory testing as well as sensory rehabilitation or providing a rich and enriched environment, what's happening mechanistically that improves the outcomes that we're seeing clinically. And given that this is a health services and public health type audience, I'd also like to present to you things that I think about training for long-term engagement and success, etc. And certainly, the group mind is always better than the individual mind. So hopefully, as you have heard me talk about the sort of things that I'm interested in, hopefully it has stoked some thoughts on your end as well. And if it has, this is my contact information. I would be remiss if I didn't mention all the folks who have helped along the way at the University of Kansas, which is where I was until just this past September, as well as all the folks that I have met with and I'm in conversations with in this local Cleveland ecosystem that I'm super excited to keep pursuing this work and magnifying its impact as we expand our research reach. And so I will conclude with that and be happy to take questions, or if not questions, engage in some conversations here.
Fantastic. Well, thank you so much. Um, Looks like we have a question in the Q&A and a couple questions in the chat. I'll start with the Q&A. So Dr. Rogers Melnick asks, is olfactory training a challenging intervention for patients to complete? Curious if multisensory therapeutic approaches involving music, art, culinary medicine could provide similar exposure while also improving adherence/motivation.
Yeah, Sam, nice to see you. Thanks for coming. Yeah, I think that's a great question. The way that olfactory training has traditionally been done is that you can do it a variety of different ways. In our studies, we use just aromatherapy inhalant sticks, right? But to your point, it's not like the most compelling thing to do twice a day on a daily basis. We tend to get buy-in for our patients that have like post-viral olfactory dysfunction, right? Because they're super bothered by this. But this is a wonderful point, if we're thinking about this at a population health level. One of my underlying hypotheses is that most of us, most modern people spend 90+% of their time indoors, right? In repetitive environments where you have the same exposures over and over again. So I absolutely think there could be a role of culinary interventions or other things where you're going to be exposed to more novel stimuli, which I would think translates into some of those improved outcomes downstream. We'd have to think of a smart way to test it, but yes, I like where your head's at, Sam.
Mm-hmm. Thank you. Okay, so in the chat, we have a few other questions. So Rebecca German says, hi, great talk. I know you thought about dysphagia. Have you done work on olfactory training for folks with dysphagia, a behavioral dependent, as we know, on multisensory functioning?
Yeah, so we haven't gotten to the point where we have now implemented olfactory training for folks with dysphagia, but we're in the process of our work, publishing our work investigating olfactory dysfunction in folks with dysphagia. And so we're seeing some interesting links in terms of the phase of dysphagia, right? So is it oral? Is it oropharyngeal? And olfactory training. And so I think that would be an excellent next step in terms of saying, okay, we see some of these dysphagia patterns are associated with specific aspects of olfactory function. Now, can we remediate that by remediating olfactory function?
Fantastic. Sorry. apologies if I butcher your name, but Parian Fatica says, I work in Alzheimer's research. Are there any studies available to add to the data on this?
Yes, so we're in the we're in the study startup process for my R01, which is being transferred to CASE, where we are continuing to enroll individuals primarily with mild cognitive impairment and Alzheimer's disease. We can talk more about the specific protocol, but absolutely. One of the nice things about the aroma test that we use is because we created it, it's pretty cost effective, it's reusable. So if there are ongoing studies that would like to add olfaction as an endpoint, this is something, obviously go through the IRB, et cetera, but this is something that could relatively easily be added as another potential outcome.
Fantastic. Scott Howard said there's evidence that some odors slash scents can influence sleep, with some studying the potential use of odorants to treat OSA. Are there areas of your physiology? Oh, sorry. What other areas of your physiology do you think could be influenced by odors?
Yeah, Scott, that's a great question. So one of the things I didn't mention in this talk, because it's kind of beyond the scope, is that odorant perception is mediated by cranial nerve 1, which is the olfactory nerve, but also by the trigeminal nerve. So there are some scents that impact both, and some scents, let me try again. Some scents like menthol type scents or minty type scents will create additional activation in a way that makes, even though there's no objective changes necessarily in airflow, it increases the perception of airflow. So I wonder if that's something that's also happening in some of these OSA patients as well, or if somehow it's subconsciously activating some of those brain regions. You know, I haven't looked into the neuroanatomy of everything that's going on when you have sleep apnea, but I would imagine if there's increased brainstem or other activation, which we could hypothesize that might be a way that these scents are providing some therapeutic benefit as well.
Fantastic. I did have a question myself too. It sounds like when you were talking about olfactory dysfunction and dementia, there was kind of a role in um, maybe like you said, mitigation or like kind of prevention, if you will. There was like a diagnostic component that you could kind of lead maybe more to the diagnosis of cognitive impairment with olfactory dysfunction, and potentially like a therapeutic component of maybe slowing or improving that. Um, is there any one like area that you think is like the best or most like likely signal to have an effect on dementia? Um, and has this been shown to like improve things like MoCA scores or, some of the other like objective findings that we've seen in dementia?
Yeah, so that's a great question. It's kind of like asking me to pick my favorite child, right? I'm like, I think we should do all these things in tandem, in terms of pursuing, the maximum value from a diagnostic side, from a therapeutic side, et cetera. For me personally, I think that there's a big public health opportunity if this is something where there's public appetite to engage in sensory retraining. And I think as well, as more therapeutics come on board for things like Alzheimer's disease, I think that there's a role identifying people early with this sort of methodology so that they can engage with those treatment options as soon as possible. And I would hypothesize that the sooner we get people into those pipelines, the more benefit they will likely see from those therapeutics.
Sounds great. And then another comment or question that popped up in the chat. Great talk, thank you. Have you factored duration of exposure to training as an important predictor for neuroplasticity from a structural standpoint to have a more lasting effect?
Yeah, that's a great question. We have not investigated that. It gets a little challenging in like real world situations, because to Sam's point earlier, it can be challenging to keep people engaged the entire time. What we have seen is that more training, so the more consistent someone can be, the better their olfactory outcomes are. But we have not done any, rigorous functional MRI or other studies to further parse out the mechanism. And like, is there a minimum amount that you have to do for this to be efficacious, or a minimum duration? Typically, the recommendation is 6 months based on some of the clinical outcomes.
I did see that our fearless leader, Dr. Bora, had his hand up. So I will obviously yield the floor to Dr. Bora. Go ahead.
Thanks, Jennifer. I have a quick question. I'm actually in an airport in a low resource setting, and you mentioned about opportunities for olfactory screening in resource limited settings, right? And are you aware of what's going on? Because there's a high burden of Alzheimer's and other similar disorders in many low resource settings, and this seems like a very promising, cost effective, opportunities. So any trials or anything that's going on that you're aware of?
So I'm going to answer this in two parts. The first part's going to seem tangentially related, but I promise it is truly related. So one of the reasons why we use essential oils in our aroma test is because there are many that are available. And that's important because cultural familiarity impacts how well you do on these olfactory tests, right? If you give me an odorant and I have no idea what it is, I will get it wrong, right? Because to be coded as correct on our test, you have to say, yes, I can smell it, and then correctly identify it on a multiple choice thing. So if I have no idea what any of the choices are, that's not because my sense of smell is bad. I just don't know what these choices are. And so our team has, when we were still in Kansas, we went to, for example, a Native American reservation, and we asked their elders, we said, we're not here to test you, but we would just like your feedback on this olfactory test. Here's what we're using right now. Here's a list of all the different odorants that we could potentially use, right? Because we know Native American communities typically bear a higher burden of disease across many different disease states. We're like, if we were to customize something as to what is really important and relevant for the folks living on your reservation, particularly your elders, what would you want on this test? And so they did give us some feedback about, there were 4 scents that they would recommend that we take off and replace them with things like patchouli and sweetgrass.
Thank you.
Fantastic. And then we have another question in the Q&A. So Shelley Jackson asks, or kind of comments, cognitive impairment, machine learning is a great topic to enhance future upcoming medical diagnostic technique approach.
Yeah, and I would say here too, we collect a lot of data. We have 14 scents at 4 concentrations, and that gets to the point, to the extent that it can be hard to analyze all of that data just with traditional statistical analyses. But I think one thing that we try to embed as well, right? Because if you create like a biased algorithm, like, it's not so great, right? Or if there's a flaw in the algorithm, obviously less than ideal. So one thing that we always try to do in our studies is to structure the data and the analysis in a way that we can do both machine learning analyses as well as some sophisticated traditional statistical analyses. And if we notice big differences between the outcomes, or the factors that were retained versus kicked out as being important for the diagnostic prediction, then we can do additional secondary and exploratory analyses of what those factors were, and try to figure out what is the reason why we're seeing those differences dependent on analysis technique.
All right. Well, thank you so much, Dr. Villwock, for presenting. I think this was really fascinating. Lots of great comments, questions. So I think with that, we are 3 minutes left. I would say maybe any final thoughts, and then otherwise we will go ahead and wrap up. Alrighty, well, I turn it over to our admin folks to go ahead and round us out for the day. Thank you so much.
Thanks, Jennifer, and thanks, Kiran, for moderating. And for the attendees, you can all find the entire schedule for the speaker series through our website, and this will also be available on our website in a few days. Thank you all for joining.